Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes, and this is another classic clinical case presentation. Today, we're going to meet Guy Sexton. Meet Guy Sexton, a 58-year-old male with uncontrolled hypertension who is tackling a major snowstorm. He lifted a heavy shovel full of snow and suddenly got a severe pain in his back between his shoulder blades that took him to his knees. His legs could not support him, and he fell to the ground, and then he could not get up. His neighbor saw him on the ground and came running out to check on him. She wasn't able to help him up. So she called the ambulance and waited with him until the ambulance got there. The paramedics lifted him off the ground and rushed him to the hospital. When he got to the hospital, the clinically astute doctor told him to tell her exactly what happened, starting with the last time he was feeling fine, and then asked him to go play by play like a story with as many details as he could recall. He said he was out shoveling heavy snow, and while he was lifting a particularly heavy shovelful, he suddenly got a severe pain in his back. He never had back problems in the past, but he thought maybe this is what it was like to pull something. The doctor asked him to describe it, but he did not know how. She gave him some extreme examples to try to hone down on the information. Stabbed with a knife, lit on fire, dull like a toothache, cramping like intestinal cramps. The patient then felt comfortable to respond that it felt like lightning struck his back. He said it was a horrible pain like nothing he had ever felt before, and it started between his shoulder blades. He immediately fell to his knees and then fell on his side. He was lying in the cold, wet snow, but he could not get up. His neighbor called an ambulance that brought him here. She asks, "Do you still have the pain?" He says, "I do, but it's not nearly as severe as when it started." Dr. Nicky asked him on a scale of 1 to 10, what would you rate your pain right now? He said 6. Well, what was it when it started? He said 12. On a scale of 1 to 10, it was a 12. It was incredibly painful. I never felt anything like it. Dr. Nicky says, "Okay, we will get you some pain medication and I will need to examine you." Luckily, she did a very complete exam, which was significant for severe hypertension, a normal back exam. The pain was not reproducible or localizable with palpation or percussion. He had profound weakness in both legs. His sensation to pain was decreased in his legs as well. She went further and found a pin level at T11. His pulses were normal in all four extremities, but his reflexes were greatly decreased in his legs. Now it's time to think. Obviously, he has a critical situation with a very significant acute neurologic deficit, seeming to originate at T11. At first, the only thing she can think of as a cause that makes sense is a central disc herniation. But why would that happen at T11? The thoracic spine is fixed by the rib cage, so how would that happen at all? Then she remembered that osteoporosis can cause the vertebral bodies to collapse in the thoracic spine. This could result in retropulsion into the spinal canal. But wouldn't it be tender to percussion on exam? Also, the neurologic signs are very symmetrical. That seems a little odd for either of those causes. Then she recalls that someone taught her that if someone has a combination of chest pain and a pulse deficit, or chest pain and a neurologic deficit, you should immediately consider an aortic dissection. She reframes her thoughts around that idea and realizes that that is a real possibility. And if that is the problem, the whole workup and management will take a huge turn. What can she do to evaluate for that? This is just a reminder. Chest pain plus pulse deficit, or chest pain plus neurologic deficit, equals an aortic dissection until proven otherwise. She did a bedside ultrasound and thought she might have seen an aortic flap, but she just wasn't sure. The chest x ray showed a widened mediastinum, so she started to believe that it really could be an aortic dissection. So she definitely needed to move fast. She gave the patient ample pain medication to significantly improve his pain, and his blood pressure responded to 150/90. She did not feel comfortable enough for their diagnosis to drop the pulse pressure further, especially if this was a primary neurosurgical disorder. She knew that a widened mediastinum is suspicious for a dissection, but it's not the only reason you might see that on a portable chest x ray. She checked the pulses in the legs again and found no deficit. So she sent the patient immediately for a CT angiogram of the chest and abdomen. Meanwhile, she consulted the cardiovascular surgeon and the neurosurgeon to make sure all the services that might need to intervene were on board. She tells Mr. Sexton, "We need to get your blood pressure under control and get you to CT scan." He quickly goes over to CT scan. While the patient is in CT, she has time to review the anatomy for a plausible explanation for this presentation, and found that the artery of Adamkowitz is located in this area, and it forms anastomosis with the anterior spinal artery. This is a watershed area of the spinal cord, which is very vulnerable to ischemia. The anterior spinal artery supplies the anterior 2/3 of the spinal cord. This will result in an anterior cord syndrome, where you'll have bilateral paralysis below the level of the injury, loss of pain and temperature sensation below the level of the injury, preservation of proprioception, which is body position, vibration, and touch. You will commonly see autonomic dysfunction, including bladder problems and sweating. This would be considered an upper motor neuron injury with respect to the legs, so reflexes will ultimately be expected to be hyperreflexic. But the immediate response to an injury like this initially is hyporeflexia from spinal shock, like a stroke. Just then, she gets the call. The radiologist confirms the aortic dissection and the involvement of the artery of Adamkowitz. The doctor is both affirmed and shocked at the same time. She goes to speak to the patient. "Mr. Sexton, it turns out your pain and weakness represent an aortic dissection. That is when a large blood vessel coming out of your heart rips, most often due to high blood pressure. Blood will track then into the wall within the vessel and can obstruct its branches. In your case, it obstructed the branch that supplies the spinal cord, resulting in the weakness in your legs. This is a medical emergency that needs to be managed immediately. We will be managing your pain and giving you medication to reduce your pulse and blood pressure so that no more blood is forced into the wall. But the cardiovascular surgeon will be in charge of the overall management from here on in. I know this is a lot all at once, but I can tell you as a doctor, knowing everything I do about this situation, if I were in your position, I would allow the cardiovascular surgeon to do what he needs to do in order to give you the best chance of a full recovery. There will be a lot going on from here on out. Is there anything I can do for you right now?" Mr. Sexton says, "Can you call my wife?" And Dr. Nikki says, "I will bring the phone right in and we can speak to her together." The patient gets rushed off to the OR, and the doctor sits down to document the case. But first, she takes a moment to collapse and consider all that just happened. She is amazed that she was able to figure this out so quickly and feels so lucky. She is thankful to her instructor that stuck the idea of chest pain plus neural deficit equals aortic dissection into her head. She is glad that she made the jump from back pain to realize that even though it was posterior, it's still chest pain. She was glad she took the extra time to get the full history and do a full exam and consider a larger differential to be sure her running diagnosis truly made sense. Otherwise, Mr. Sexton could still be an MRI right now looking for a central disc as he dissected further during the next hour or two. Wow, she thinks, this is truly a really cool job. All right, let's check in on Guy Sexton a month later. An aortic dissection with involvement of the artery of Adamkowitz is a technically very difficult problem to fix. The doctor will typically put a stent in the aorta where the initial intimal tear is located to keep more blood from moving into the dissection. But since the vessel is already obstructed, it needs to be addressed as well. Luckily, they were able to stent the flap and restore the blood flow to the spinal cord quickly. Thank God and the ER doctor for getting the patient to the OR so quickly. Thank you so much for learning with me today. Check out the classic clinical presentations on my YouTube site. And if you are interested in full course content, check out medicaleducationinminutes.com. Okay, see you next time.